Welcome back, everybody, to a podcast to answer your questions on addiction, recovery, and mental health, produced by Waismann Method Treatment Center and Rapid Detox. I'm Dwight Hurst. I'm a clinical mental health counselor and honored, as always, to be the co-host for today's program. This is our last broadcast of 2024, sure to go into the history books. We've had a great year of being able to talk about addiction, mental health recovery, and we've had some wonderful guests join us too, which was a new part of this project we were able to do this year, was to have some people join us and tell their stories. And we're looking forward to continuing that, as well as answering your questions about detoxification, the addiction recovery process, and mental health. I'm joined by our wonderful panel of experts from here at the Waismann Method. We've got David Livingston here. Hi, David.
Hi, good to be here.
A licensed marriage and family therapist. David is the psychotherapist and clinical lead. He's an expert in the psychological needs that are associated with addiction, with recovery, trauma, and just all sorts of good, cool things to help with that recovery. We're also joined by our medical director, Dr. Michael Lowenstein. Hello.
Hello.
Dr. Lowenstein's a globally recognized authority in anesthesiology, pain management, and rapid anesthesia-assisted opioid detoxification. Did I do all the words right?
Yes, perfect.
Michael? Okay, good. Just wanted to make sure. Well, as always, it's interesting to me, and I noticed this working in the field, to have so many people that are just people we get to meet every single day. And I have very much enjoyed working with throughout the years in this podcast, because there's such a wealth of knowledge for us to learn from, just from each other. So that's my gushy end of year comments about you guys. But why don't we get into it? We're going to focus today on some of the trends and some of the elements that we're seeing in addiction treatment, in mental health aspects, as well as pain management and some different things with medications. We're gonna talk about how those work together with recovery. So let's dive into this and say, first of all, what do we find to be when people are getting into this mode of recovery and health building? What are some of the strategies that we like to recommend, or that you see work well for people when it comes to that? And I think, we've got on both sides, we've got the real physiological side of medical, and then we've got the psychological side of the medical recovery that people are going through. So where do we want to start with that? What are some good strategies to maintain progress in this area?
You want to go, Michael?
Sure, I'll go first. So as we've discussed in the past, patients that are opioid dependent, or any substance of dependence, but my focus is primarily opioid, is once you've been able to recognize the problem and be willing to seek treatment. So the question is, what are some of the options? And we've got traditional options, we've got inpatient, outpatient detox. There's maintenance drugs like methadone and Suboxone. And then what we do is rapid opiate detox under sedation. So, and everybody has different needs and, comes to these decisions differently. So I think the first is to acknowledge that there's an issue and seek treatment. And then, once we've helped to establish medically, and there's no one size fits all for anybody. And a lot of the patients I treat have tried other things and or maybe had short-term success or relapsed. And so we have to figure out what works for the individual. And then, the medical only works side by side with the behavioral, addressing those issues as well, where David kind of comes into the picture.
Yeah. Just to add to that, right, you might think of, from a more emotional or psychological perspective, that a lot of addiction is just an attempt at affect regulation. So that the opioids, which is many different forms that we treat, is an attempt to regulate physiologically and emotionally some form of dysregulation, and it come from many different things. And we see a lot of people with really chronic sleep problems, which creates a big form of dysregulation. It doesn't have to be that, but that's a common thing that is going on and usually untreated. Some people have attempted at it, usually unsuccessfully. So, so that's just an example of sort of what can cause affect regulation on many levels. So it's both physiological and, of course, then it becomes psychological as you move into perceived helplessness and levels of frustration. And then, the two are pretty intertwined. So I think that there's been a movement away from, and maybe the last thing to say about it is, so it's often talked about as that addiction is talked about as a model that is, can't think of the word I'm trying to find right now. It's a, what's the word I'm trying to find? Disease model. Thank you. Okay. The disease model is right to some degree because it acts upon you. And so what was once thought of as a failure of your character is now seen as problems with affect regulation. So the disease model, which when I hear people talk about it, they usually say it's a disease. It's not exactly right. There is no pathology nor pathogen that is being sort of seen, oh, this is what's causing it, but it is a disruption. So the disruption acts upon you. So it is a model that sort of moves in the same way. And then a lot of the treatment that follows both physiologically and emotionally has to do with what is going to help regulate you and sort of move you to a place of better health and feeling better overall.
It strikes me that both of these areas, I'm gesturing to where you guys are on my screen, both of those areas relate to, do I regulate and find actual maintenance or curative factors for the underlying reasons why I might go back to dependence or to drug use, or maybe why I did in the first place. In other words, if it was a form of self-medication, do I have attending health problems that could set me up to get into problematic use? Do I treat those, right? Am I stabilizing in ways that are more healthy? Because the needs aren't unhealthy. It's just the addictive solution for the needs, right?
Yeah. And I would say, you do have to address both of what we spoke about. And I've always said, I've been doing this now for 25 years and said, people do drugs for a reason, right? Mm-hmm. The reason could be the underlying psychosocial issues. It could be chronic pain. But regardless of what the reason is, from my perspective, everyone I treat is opioid dependent, right? And opioid dependent is a medical issue. Opioid dependence is a medical issue. And the one thing I didn't talk about is, the game has changed since I started 25 years ago. There was heroin out there, and some of the Vietnam veterans that had come back and were still on heroin we treated. And there were the pills like the Norcos and the Vicodins and things like that. But the fentanyl has really, really changed the game. It's incredibly potent. The overdosage have gone up significantly. We now find xylazine, trank in the drugs, which has changed the game, and it's relatively inexpensive. So the amount of drugs that people are taking that come to me are just enormous, and it's really made more of the traditional treatment options more difficult because the drug usage is so high. So, everyone that comes to see me is opioid dependent, and I still think if we can treat that opiate dependence, and I use naltrexone to block cravings. So if we can treat the dependence and block the cravings, the patient's ability to address the underlying issues is so much easier than when they're still dependent. It's easier for psychiatrists to make diagnoses when the patients are off the drugs and they're not craving and withdrawing. So I still think the medical part, it's important to address whichever way. And I'm, a fan of what I do because we completely get the patients off opioids. block the receptors with the naltrexone or Vivitrol, the injectable form. And then, David's then able to hit the process of identifying the underlying issue, the why are the patients using drugs? And I think it's important.
Excellent. Well, there's new trends nowadays in pain management. There's a lot of different practices and research that's been going on with trying to go beyond opioids to look at that, which hopefully, obviously, one of the upshots of that would be reducing addiction risks, as well as hopefully finding things that don't have the eventual, opioid-induced analgesia, things like that we see. Dr. Lowenstein, can you tell us a little bit about what's going on there with pain management?
Yeah, so there's a lot of exciting things going on in the pharmacology world for both pain management and then addiction as well. So with regards to pain management, there's the FDA is currently looking at a new drug that relieves acute pain, but it doesn't utilize the opioid receptor. So it theoretically would cause less risk of dependence, addiction, things like that. The orthopedic surgeons have gotten very smart. It used to be you'd get a knee arthroscopy and go home with 30 or 60 or 90 Vicodin. They're now using combinations of anti-inflammatories and local anesthetics that they're injecting in joints postoperatively. That's significantly reducing the need for opioid medication afterwards. And so in that arena, in the orthopedic arena, the problem was twofold. One was people that had previously been dependent on drugs, that the brain gets a taste of opioids again, and there's relapse. And then, some people just like the way that opiates make them feel. It's interesting. Some people, it causes dysphoria, and, the risk of them abusing is very low. But other people, it's like, oh, it gives me energy. I feel so good. And, and that becomes a slippery slope. So after total joints, they're infusing local anesthetics. So there's a lot of non-opioid medications. And then in the chronic pain world, we're doing stuff like interventional injections. We can treat facet arthritis by burning the nerves. We can implant spinal cord stimulators, things like that. So for those chronic pain patients. And then there's really been a push towards more physical therapy, occupational therapy, yoga, Pilates, things like that. So, when I started my career, very few people got opioids, my pain career. And then, with the whole OxyContin, epidemic, that changed. And now I think we're cycling back to where we're looking at non-opioid methods. Mm-hmm. And then in the pharmacologic realm, you're looking at like Ozempic and Mounjaro, the weight loss drugs. The nervous system is very complex, and we're now finding out that there's overlap. So these drugs that were prescribed to lose weight, and they actually work by.
Yeah, that's an interesting new trend, that we are seeing with a lot of the weight loss drugs. I know that with Ozempic, my targeted ads or whatever it is, maybe they know something about me weight wise, but I get the targeted ads on social media. It's all over the place. I will now too, now that we're talking about it. My phone's probably listening to me. But a lot of people are using that even just in the weight loss area. And then to say that there's been some indications that it can help with addiction.
Yeah, I'm hearing that from people who are using those drugs too, that they're actually finding that they're feeling less compulsive overall towards, any sort of unwanted substance or overeating or things of that nature. So I think, as Dr. Lowenstein was saying, we're just figuring out. I think it's new, and I know there's research. I've been reading a little bit of it, but I think they're just beginning to put it together. But it's promising, and I think that what drives behaviors in terms of the nervous system, the brain, affect regulation, and all these components are kind of beginning to sort of come together, and then pulling them apart and seeing sort of what makes a difference, and being able to have enough knowledge and access to good treatments where you can try things and see, assuming that it's indicated, if it's really useful to you.
Yeah. Well, and I know that I have this discussion with people all the time, which is when you do come across research, those that write articles love to put, this is what we found in the headlines and even in the articles themselves. If you actually talk to researchers, they're always like, well, let's slow down a little bit there, because they actually want to answer the questions. And even when we get to the point of doing human trials and having people actually be part of the research studies, it's always good to keep in mind that it's like, we know that something significant might be going on. That's it. And until they don't make declarative statements very, very quickly. And then at the same time, some of the research is looking at the effects that it has, whether or not they know what it does. It looks like we've got.
I'm back.
There
I'm
we
sorry,
go.
my internet just went down. Do you want me to keep going, or where I was?
Yeah, well, we were actually just talking about some of what people are seeing and the hope that the Ozempic is giving them. It's nice that you jumped right back in right as I was wanted to ask you a little bit about why might. And we were just saying, like, research, is one of those things where we can get indicators, but I don't think we often don't know yet. But why might the Ozempic be helping was in terms of receptors and what it done be doing in the body and brain.
Yeah, so it looks like the GLP-1 and GID agonists, they actually work on the mesolimbic system, the part of the brain. And again, there's so many cross connections in the brain that I think we're still at the very tip of the iceberg about discovering how addiction and all these things work. But it looks like it reduces appetite and triggers satisfaction in the brain. And that's how it actually controls addiction. So as a result, you feel like you're full or you eat less. And so the weight loss comes through that effect on the whole mesolimbic system. And so for that reason, it looks like it's effective for opioid and alcohol use disorder as well. And there was a recent article that came out in the Journal of Addiction that they looked at 500,000 people with opioid use disorder. And there was about 8,000 people that were also on one of these agonists like Mounjaro or Ozempic. And in that group, they saw a 40% reduction in opioid overdose. And in the alcohol group, there was about 800,000 people, and maybe almost 6,000 of them were on one of these drugs. And they saw a 50% reduction in basically intoxication from alcohol. So there's definitely a cross reaction. And we see it with naltrexone, right? It's a pure opioid mu agonist or antagonist, excuse me. So that's why we use it after detox to fill the receptors and block the cravings and reduce the risk of overlap. But it also works with alcohol. And they've even started using it with weight loss and combining it with Wellbutrin. So there's definitely a lot of crossover. And it's interesting, even naltrexone in the dosage we use to block opioid receptors, if you use it in very low dose, like 1/10 the dose, they show that it increases inflammation in the body. By the way it affects glial cells. And so it's being used now for MS. It's being used for fibromyalgia pain. It's being used for a lot of these chronic pain states. So, naltrexone is a pure mu opioid antagonist. So it's a very pure reaction, but it seems to be working by other mechanisms in so many other body systems that I think hopefully they'll be able to design drugs that are more specific because, like these have side effects, nausea, vomiting, GI issues. But somebody who's overweight, it's interesting that people that I've treated with fentanyl, which are now about 80% of the patients I treat are all fentanyl, the amount of weight gain in the past 2 years, because I asked that question, what was your weight 2 years ago and what is it now? And a significant number have gained 20 to 50 pounds in the past 2 years or while they've been on the fentanyl. So if you can get the weight loss, which will have positive health impacts, and you can reduce, the risk of relapse or cravings, things like that. And there's a lot of potential. I'm not sure I would use it primarily to reduce, overdose and things like that because of the side effects. But if it can provide benefits, for both, that'd be excellent.
Yeah. There's a balance there that happens when people have and this happens with detox in general, right? When people have a reduction or a success with the chemical underpinnings and the dependence issues that way, and those kind of chemically induced cravings. Then on the other hand, there's the habitual and the way we think and the way we go to problem solve with intoxicants. And David, what's the relationship there where that ratio starts to shift and the chemical cravings are down? How much do you see people's just habits and they're either behavioral or cognitive habits kick in to where I'm used to going to this for help,
I think when there is positive reinforcement, there's positive reinforcement. So if you want to lose weight and you're having success, it tends to help you feel better overall, both in terms of your goal of losing weight, and then also emotionally, you feel like you feel better about things and whatever the importance of the losing the weight means to you. You also kind of feel like you're regaining control of your life in a way, and since I've talked about perceived helplessness and frustration as being one of the triggers, big psychological triggers for moving people into compulsive states. So when you're having success, you're moving out of a state of compulsivity because frustration's going down because you're having success, and you also you're not in a sense of perceived helplessness because you're having success and things are working. So the more things work and the better things go for people, the more they want to continue that and also keep rewarding themselves. It tends to create that sort of a positive spiral. And in that way, I think it's heavily correlated.
Mm-hmm. Speaking, you had brought up fentanyl just a minute ago, Dr. Lowenstein, and we've talked a lot about how the overdose crisis, and as we like to differentiate here on the show, there's increased overdose deaths, but then we also like to point out that a lot of those are actually poisoning deaths, right? Where people are being given things that are poison. So we don't want to ignore that, and I think we're very, very conscious here about victim blaming or patient blaming when it comes to the language that we use. So I just want to throw that out there. But as far as with the fentanyl crisis of fentanyl being present in so many drugs, I was curious about the trends and how is that affecting the way people act, the way that they avoid drug use, or the way that they relapse or do or don't relapse. We thought it'd be worth a mention here. One of the things that I've noticed is that there are times where people that I'm working with, they may have strong relapse cravings and they may actually relapse to intoxicant use and overuse. But some of them, even if they have an opiate dependence, shy away from street purchased opiates or heroin because of the fear of fentanyl. And they may go to other things thinking that they're safer. I mentioned as we were setting up the recording, I've had some people I've talked to who have tried to use kratom thinking it would be safer than taking a chance, something you get at a smoke shop or something in some states, or overuse of alcohol sometimes to avoid what they think of as the risk of fentanyl. I'm curious if you guys are seeing that anywhere.
Yeah, I am seeing a lot more kratom. And kratom's interesting. It's a plant that comes out of Southeast Asia. And a lot of times the workers in the fields will chew the leaves of the plant because it has opioid-like effects and it also has stimulant effects. And so the amount that I think you get from just chewing a leaf, it allows them to be functional and things like that. And the internet, there's been more and more information that kratom can be used to help people get off of more serious opiates like fentanyl. I've recently had a patient that used it to stop alcohol. Where it becomes a problem is because it does have opioid-like properties, is that they use more and more and more to try to, when they discontinue the opiates, to try to treat the withdrawal symptoms. And you can become opioid dependent on kratom. And what's available out there by internet or in smoke shops is there's more and more concentrated liquids that are being produced that just have higher and higher quantities of the chemical that's in kratom. And so people, when they stop the kratom, develop opioid withdrawal symptoms. And, especially as you take more and more and more of the really highly concentrated elixirs or liquids, and then you're dealing with opioid dependence, but from kratom. So, yes, and I have heard of people being successful, but it also, everyone has to be aware that it can lead to dependence itself. And then when you withdraw, you're dealing with, another opioid that you need to be potentially treated for.
Yeah. The fact that it leads to dependence and withdrawal is one thing that I think is a big, well, it doesn't seem like everybody knows that going into it, that they should expect that that's going to be part of it.
Yeah. And that's definitely not advertised.
Sure.
So,
yeah, that's not, they don't have a little sign by the cash register at the smoke shop.
That may cause dependence and withdrawal when you discontinue it. Yes.
And from what you were saying, Dwight, that you know of people who've overdosed from it too. So, I mean, with that in mind, it's, so it can become, at a certain level,
Sure,
really dangerous as well.
Yeah, I think that sometimes the legality of something will lead people to think it's okay, or the fact that you can go on Reddit and someone will say, hey, here's how I got off of opiates using kratom. And you'll see comments that are really, really like, yeah, this stuff's fine because it's not talked about very often, maybe.
And it's over the counter, right? So it doesn't
Right.
require a prescription. So oftentimes, it's kind of like anti-inflammatories. The number of people that die from GI bleeds from using over-the-counter Advil or Aleve is significant, or Tylenol toxicity and liver damage. So kratom's available in smoke shops, over the internet. So it's got to be safe, right? Because it's over the counter.
Right. That's the perception a lot of times. I wonder if you've seen this in your work with people, both of you, that one of the elements that I see as a psychological risk factor for continued addiction or sliding back into more addictive behaviors is the desire for, let's say, control, maybe over things, that in a sense of like, if I can just go buy something and take care of it myself, whether take care of it, in air quotes here, then I'm going to do that rather than go and talk to someone and get something that's maybe medically approved and has some studies and some work, and, shying away from asking for help and support or having a community orientation around the problem that I have. I'm not saying everybody with addiction has this, but I just see it as a risk factor that exists, is I guess got to do everything myself.
It's a big risk factor. I think that one of the things that you'll see a lot with someone struggling with a substance abuse or dependency is that there's been gaps in healthy dependency, where they've reached out to there's problems maybe earlier in their life or in other ways, or they've gone in for treatments and haven't been successful, either because it wasn't the right fit, or they got medications or help that wasn't successful initially, and there was a lack of persistence. And underneath that is kind of this vulnerability towards reliance anyways, for usually there's deeper issues around that. So they'll quit. They'll kind of go to whatever it is that has been successful for them or helps them initially. And if their dysregulation gets severe enough, then they can really turn towards things that are more dangerous. But there's a huge correlation. I think one of the things that when people say, well, what does it take to get better and be successful? One of the things I say is, well, find people that you have confidence in, that you can count on, that are going to work with you and build a relationship with them, and then stay at it, persist, right? Just, things aren't going to always, if you go in and you're trying to get help with sleep, you may try a few different things that won't work, maybe even make you feel worse initially, but there's a good chance you can figure it out over time. So, but it's hard because I think on our own, we have blind spots. We tend to overestimate or underestimate things. So, we constantly need feedback in order to kind of get to where we need to go. I think it's a human thing. And if we have good help, it helps in, getting us where we need to go. And also we're better off when we're accountable to other people, not because we have to, but because we want to be, because there's a good relationship. And that accountability is also a strengthening factor, right? That, so all of that I think helps.
Goes back to that reinforcement you mentioned before. Healthy behavior can reinforce more healthy behavior.
You bet. Yeah.
Another thing that's become much more prevalent, which I don't think we've ever talked about previously, is the fact that a lot of the physicians that practiced during this whole OxyContin, the whole opioid epidemic, are now starting to retire. So there's a lot of patients out there that have been on, either 6 or 8 Vicodin or Norco or Percocet for years and years and years. And now the doctors who have a good relationship with these patients and know the patients and know that there's, they're dependent, but there hasn't ever been an issue. Now they're all of a sudden they're retiring. And the younger group of physicians that grew up being aware of the opioid and, being afraid to prescribe opiates because of all the, the crackdown on physicians prescribing opiates and everything else, are not comfortable with prescribing. So all of a sudden, these group of patients are now looking for new physicians who are not wanting to prescribe opiates. And it's a lot of times rightfully so, right? Because, if you look at the recent studies that show, opiates are great after accidents and after surgery, but long-term opiates, studies show that they're probably doing more harm than good. So now we have this entire population of patients whose doctors are retiring and nobody's going to prescribe for them. So what do? They don't want to be sick. So they end up going to the street, and fentanyl is very available. And you'd be amazed that people you'd never in a million years think would be going to the street to buy fentanyl, people with families and jobs and, not your stereotypical drug addict. And I don't like that term, but someone you'd never expect.
No, right. There's an air quotes there too,
right,
for anyone who's just listening to the audio.
But now these people that, they don't want to be sick. They've got a family, they've got jobs, they've got responsibilities. And now these are the people going to the street to buy fentanyl. So that's something we also have to address. So going back to the behavior, I think we have to recognize that they are dependent and that they probably need to be off these opiates. If no other reason is to reverse the opioid-induced hyperalgesia and determine what their real pain is. But then they need the behavioral support to deal with whatever underlying issues there are. And then they need good medical treatment to treat the dependence. So there is that as well that we're facing now.
Yeah, and I think that the new crop, so to speak, is you're seeing medical professionals who have also grown up, hopefully, in a field and a world that has a little bit less stigma. And we still see that stigma, as you just put, right? People have a perception. If you say, picture a drug deal happening on the street, there's an image, right, that people have of what that looks like and maybe who they think that looks like. And there's probably a range of what people think, but the more exposure you have to the world of addiction, you might find that your idea of who that person looks like that is purchasing is much more wide and varied. And also that stigma kills people, because then we don't turn to our neighbor or our friend or our loved one and say, you okay? Because they would never, they're not, they seem a little, it's a problem, but they would never get heavily enmeshed in that world. And how would they even? And it's like, oh, you can. And we do when we get into that. So that stigma going down also, I think, helps over time.
Yes. And hopefully this new crop of physicians as well, they've had more training in functional medicine and behavioral medicine. And when I trained, if you had a pain, you were prescribed a pill. So hopefully they'll be able to utilize the other things that they're being trained with now, as far as functional medicine, and they'll be able to utilize some of those skills to help deal with the issues better than when we were first trained in, the model where everything requires a prescription medication to deal with.
Mm-hmm.
Yeah, and if you are unable, if your doctor's retiring or there's a reason that you're unable to be prescribed the medications that you've been getting possibly for many, many years, it's critical that you not feel ashamed to ask for help. And a lot of people do that there's this, they're afraid of being, that there'll be a stigma and the medical profession, can do that too. I know a lot of people are afraid to tell their doctors what are going on, because if they find out they're on an opioid or something like that, they move them into a different category. And I think that, I think there needs to be a different philosophy. I understand the fear that a lot of doctors have, like you're talking about, Dr. Lowenstein, of sort of continuing prescribing and that it's often not indicated. At the same time, I think there has to be some process of helping people sort of move to a safer and better way to go. And there haven't been great options for that. Mostly it's been either Suboxone or methadone. And but that's really, really hard to get off of, and sometimes much harder to get off than the opioids they're on, particularly if they're on a small amount. So it's a complex thing, and I don't think that it's talked about very well. And I'm glad we're talking about it because of that. And I think part of why what we do is we get people off of it, all of it. So, there's that option. It isn't just moving to something else. And that is also very hard to get off of. And as I said, often harder to get off of, but safer than being on fentanyl, that's for sure.
Absolutely.
Yeah. And that is one of the beauties of rapid opiate detox, is that the patients will call up and say, my doctor's retiring. I have this many pills left. I don't want to be sick. What are my options? So they come and we treat the dependents and they're done. And then they can move on, and, they can, for the first time in a lot of years, figure out what is my true underlying pain. I've been on pain meds for so long. My surgery was 10 years ago and I'm still on pain. Do I still have, pain meds? Do I still have pain? Do I need opiates? That's a very viable option in this case.
Well, and for people who are really just have been on them long term, like the group we're talking about, have been maybe helping with some sort of pain issue, who don't want to move on to something like Suboxone or another medication, which is usually what's suggested. Occasionally someone will say just wean down. People usually are unsuccessful with that. Occasionally I hear of someone being able to do it, but not usually. So I think that the idea that you can actually get off it completely is it's a good thing for many, many people. That they don't need that interim phase of being on a different medication.
No. Well, thank you, gentlemen, and also thank you everybody out there who has been listening. We're really, really grateful for everybody who's become a part of our little listener family out there, who follows us and is nice enough to share some of the things that we share, and hopefully find it useful to share with those that you know and care about as well. That is our goal, obviously, on this show, is to spread information and support, so you're not alone, and that there's hope to be had, as we always like to say. We want to hear from you and your questions about mental health, about addiction, recovery, also about detoxification, especially rapid detox. It's an area that there's lots of interesting information, but not always a lot of knowledge about where to find and look for it. You can always hit us up with any of those things at info@opiates.com, or to go to our website, opiates.com, to call or contact us as well. We're also very active on social media. We're at Opiates on all the big platforms. And we're just grateful to be here with you. Remind everyone out there that you should keep asking questions. If you ask questions, you can find answers. And when you find answers, you can find hope. Thanks again, everybody.
Thank you.